Today we are going to learn something about popliteal or Baker's cyst. These cysts are commonly encountered in orthopedic practices that treat knee disorders. The formation of these cysts in adults is frequently found in association with an intra-articular disorder in 94% of the people, and a meniscus tear is the most common cause, followed by osteoarthritis. There are some differential diagnoses for these popliteal cysts like popliteal artery aneurysm, soft tissue tumors, meniscal cysts, hematoma, and seroma. The pathogenesis of Baker's cyst is explained by the presence of a connection between the knee joint and a bursa between the gastrocnemius muscle and the semimembranosus tendon, allowing the flow of fluid. There is a valve effect between the cyst and the joint due to the action of the semimembranosus and gastrocnemius muscles. During flexion, the valve opens, and during extension, the valve closes due to the tension of these muscles. Moreover, the intra-articular pressure of the knee interferes in the formation and in the filling of the popliteal cysts. The intra-articular pressure during partial knee flexion is negative, -6 mm of mercury, becoming positive with knee extension, around 16 mm of mercury. Hence, these three factors, that is, the presence of communication between the joint and the bursa, valve effect, and variation of the intra-articular pressure in the knee, correspond to the formation of the popliteal cyst. This is a 40-year-old female who presented with a swelling on the back of her right knee since last 2 months. The most common site of the Baker's cyst is between the medial head of gastrocnemius and semimembranosus muscle. They have been reported in other areas, but this is the most common site. Symptoms related to a popliteal cyst are infrequent and may be related to its size. The two most common symptoms are a popliteal swelling and posterior aching. Functionally, some patients may develop loss of knee flexion from cysts that are so large that they mechanically block flexion. For the physical examination, we should assess the patient in prone position and perform knee palpation in extension and in flexion of 90 degrees. We can palpate around globular swelling with sensation of fluid content and of well-defined edges. The cyst tends to disappear or to decrease with 45 degrees of knee flexion. This is called as the Faucher's sign. This test is useful to distinguish it from a fixed solid masses that do not change position. Now I shall be demonstrating aspiration of the popliteal cyst. Before aspiration, one has to thoroughly clean the popliteal cyst with a betadine 5% solution. Let the solution dry out. Now, with a 16 gauge needle mounted on a 20 cc syringe, I am placing the needle into the cyst and am aspirating the cyst. As you can see, the syringe is slowly filling up with a highly viscous yellow colored fluid. As the cyst is being aspirated, you can see that the cyst is slowly disappearing. As we can see, I've aspirated around 24 ml of the cystic fluid from the popliteal fossa, and upon re-aspirating, I cannot aspirate anything. So the aspiration is complete. As we can see, the previously evident popliteal swelling or lump has disappeared. Here we can see that the fluid that has been aspirated from the Baker's cyst is quite thick, viscous, and it's almost gel-like. Thanks for watching.